Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
This is the show.
Hello, the show.
Yes, because it's Dr. Mark Vaughn and Dr. Gwen Vaughn talking about stem cell therapy. People have been waiting for this.
This is exciting. Cutting edge.
Don't get stem cell therapy until you've seen this show.
Wow. You've heard it here.
So we've talked previously in weeks leading up till now about what were the things?
Prolotherapy.
Prolotherapy and PRP. Platelet-rich plasma. To me, and I don't know if it was surprising to you, but a little surprising to me that it was as good as it is for, was it knees?
I think it was
I need to go
different for each one of those. Yeah, knees were the big ones. I think where they're finding
but surprisingly good and better than what we've been doing with the cortisone
steroid injections
long term. But then we also
for
found,
the PRP.
Was it for tennis elbow that the best thing was just watchful
Physical
waiting.
therapy. Don't do anything.
If you want the best results, just let it get better. Yeah, physical therapy.
Yep.
Okay, so we're going to jump into the stem cell therapy. Also, this is a live program, and we right now have a chat running, and we put it on screen so that it's a dialogue about what's going on. You can ask questions. You can do super chats to get your questions prioritized. If there's a particular joint you want us to start with, shoulder, knee, maybe we'll do hip.
Shoulders, knees, and toes. No, not your head. But shoulders, knees, maybe toes. I don't know. I don't know about toes.
So until we get some
I don't know anything about toes and stem cell injections. I have no idea.
Before we get to specific joints, give you a chance to chat in what you want to have done. Let's give a little bit of background.
On stem cells, yeah.
So the big thing with stem cells, to my understanding, is in the world of, and we do need to cover where they come from too, but the world of Parkinson's disease and type 1 diabetes.
Yes, that we're seeing huge strides and improvements in people.
But I don't think it's yet to the point of being
mainstream. I've seen the studies. I have not heard that. Okay. Yeah. I've not heard say, hey, refer to me because I'm doing this on everybody and that's what you should be doing.
Yeah. And so because we've known about stem cells being used, and there's kind of related, like the bone marrow transplants for people with aplastic anemia, that's been around for decades. So related types of therapies have been around, but when I think of stem cell therapy, I really think of like the Parkinson's, the neuroimplantation, or for injury, and originally it was actually embryonic stem cells. Is that correct?
I think they were getting some from there.
Even from aborted fetuses, I think was.
Yeah, and I think that was one of the.
Yeah, that slowed its development because.
Yeah, moral objections, I guess you would call it.
Yeah. And then umbilical cord cells.
Right.
And then self-donated or autologous cells coming from liposuction.
I've heard that, liposuction or bone marrow. Bone marrow sounds like such a invasive way to get your stem cells just for a knee injection.
And then if it's not autologous, you're getting it from someone else.
Right, which then you always need to think about a reaction to that because your cells or your body will see it as foreign.
Your body. Mm-hmm. Yeah. So that's the background of it. And that's why when I hear about people going out of state to get stem cell therapy for something that's bothering them because they can't get the treatment in state, I start to wonder, it kind of smells of, is this something a person should be doing? Is it actually a medical doctor they're going to?
Right.
Why do you have to go out of state or out of country? And is it really what they say it is? And sometimes it's not.
Right, yeah. With these kind of, it's not fringe science because we do have data to back up these things, but these kind of cutting edge science technologies and you have to go somewhere, I mean, there are going to be some questionable people taking advantage of that. So you do need to make sure that it is from a reputable source.
Yeah, when I think of stem cell therapy, I think of usually central nervous system and then some kind of a research institution.
Yeah, that's what I think of
Stanford,
too.
UCSF, Mayo, Harvard type thing.
Yep, where you're actually enrolled in a study where they're following you.
Right, and so for somebody to just be going to a private clinic in another state.
Where you going? Indio?
Indio?
I don't know, of all places.
Okay, let's see what is going on out here. Okay, Lindsay Antwine. Thank you, Lindsay Antwine. In fact, we want to feature Lindsay Antwine as an example of how to chat early
and often,
and how to
kind of like voting.
Do the Patreon. So thank you, Lindsay Antwine, our prime Patreon supporter. She says, I've had bone marrow biopsy. It's not that bad, just feels weird. Honestly, I've heard some people, it's fine if you get numbed up well.
Yeah, I think that's kind of the big thing.
You feel a lot of pressure from it. And I'm sorry that you had to have that done to you.
It is an invasive procedure going into your bone to harvest some of your bone, the marrow in there.
I should point out, you'll notice that with Lindsay Antwine's picture, it says membership because she's actually a YouTube channel member.
That's
like something that some people have
gold-plated.
Gets you special recognition.
Solid gold.
No, solid. Okay, we have another comment here before we get going. I've had bilateral knee replacement years ago, and they both hurt daily. And I think last time we came out with a surprising endorsement for that barbaric procedure because
for knee replacements
because it's effective at getting rid of osteoarthritis, knee pain, and letting people walk.
This person's saying that it hurts every day, though. That's unfortunate to hear. The goal of getting a knee replacement is that you... and the question is, does it still hurt?
I was going to say...
It's really what we want the clarification.
I'm not clear. Is it... and they both hurt daily. The second line was daily.
Yeah.
So I guess...
It's still hurting, which is...
years ago.
Not the typical outcome we expect with a knee
I won't say I never see somebody who has a complication or
I see them occasionally.
Has pain after having it. I have seen it. So I'm sorry, Janet, that happened to you. But the overwhelming majority is they do better.
Right.
And of course you have to account for anytime there's an operation. There's risk there. And a lot of times...
Right. And maybe is this not due to that? Is there something else that happened during the surgery or... somewhere in how it was placed or not aligned right, or there's a lot of things that can go into that.
Yeah, it's not every patient is a candidate. We'll say it that way.
Yeah. Okay. And it's a joint that you're using every day and stressing every day as you're walking. So it is. Yeah.
Oh, Janet. I have severe arthritis too.
Severe arthritis, yes. That's typically what we consider.
Usually leads to the knee replacement.
Typically what we consider doing these injections for. So we kind of went through the other ones, now stem cells. And the big question,
so let's
talk about knees. We could start there, unless somebody else has something.
We will. No, we won't start there.
Okay.
And the reason is because...
I will follow your agenda.
Okay. I was going to start with a general statement here.
That sounds good.
So that people can see.
Generalities.
Yeah. Before we dive down, it says, current evidence does not support stem cell therapy over conventional treatments for most musculoskeletal conditions. While some studies show promising short-term improvements in pain and function, the evidence quality is generally low, and robust placebo-controlled trials demonstrating superiority to standard care are lacking. So that's where we're starting.
Well, that is
with kind of a general
downer.
Statement. Okay. So let's jump to, you said what?
But knees.
Okay.
Since you were talking about knees, and
I'll jump to knees.
I think if anything has the data from my knowledge of stem cells, it would be knees, right? What do we find?
I would think so because of what we found with the PRP.
Yep.
So jumping to knees, we have knee osteoarthritis. For knee osteoarthritis, stem cell injections may provide modest benefits. once
May.
But evidence quality is low. A 2025 Cochrane review found that compared to placebo injection, stem cell therapy may slightly improve. Okay, may. We saw the magic word. What's may mean?
It means it's not for sure.
I mean, it also may not.
Yeah. That's like hedging your bets.
That's the magic word in these studies.
Maybe.
It could just as well have said may not.
Right.
Anytime you see may in results of a study, think may not.
May not.
Okay.
Yeah, and if we look at those numbers, if we go back to it,
let's go back and look at
1.2 points on a 0 to 10 scale.
How much better did you get?
The question is,
I got better by a 1.
Yeah. So we talk about statistically significant versus clinically significant. So you can run these tests and run all these things and run the data and come up with a statistically significant result which shows an improvement. But then you go into somebody in your office and say, I gave you that. You were a 7 yesterday. What are you today? A 6? And was it worth it? That's the big question.
This is somebody being asked that question and giving you a number. And depending on other things that happened that day, unrelated, the number may be different. So the review noted uncertainty about quality of life, treatment success and safety, and very low event rates for serious adverse. Well, that's good. Low rate
seems to be safe.
Yeah,
which is good. Do no harm.
It says certainty was low due to heterogeneity in stem cell sources and preparation methods. We had that last week.
Yeah, I know that continues to be a problem with these. There's no standardization, and that's what is needed. When I give a steroid injection, I know what I'm giving. I know the studies that have been done at that dose and the expected outcome as a result. That's standardized, right? Yeah. For this, it's still on the fringe where it hasn't been standardized.
Yeah. So the preparation,
where
they could sell some, how they process them before they put them in, that all leads to heterogeneity, meaning it's different.
All over the place results. That's what that means. The results get all over the place as a result.
More stuff about knees here. I'll go ahead and show this to you, what I'm reading.
I think I was going to say, we're talking about the hyaluronic acid there.
Okay. Multiple meta-analyses suggest stem cell injections, particularly adipose-derived mesenchymal stem cells, so these are the ones from fat in somebody's body, show better outcomes than hyaluronic acid. That's the stuff that the orthopedic surgeons are injecting into people's knees, the Duravisc and the Synvisc.
Yep.
So that's interesting that it looks like it's better than that.
Multiple studies show that.
One 2025 meta-analysis found MSCs superior to hyaluronic acid at 12 months for WOMAC scores. I think we came across that last time. Pain and cartilage repair on MRI. Oh, that's interesting. Cartilage
repair.
Oh, that'd be because
that's interesting.
That would make knee replacements
obsolete. I mean, not obsolete.
Yeah, I like the obsolete word, but I'm like the guy who wrote May. Less necessary. Okay. Yeah. Well, that's wow. Okay.
So that's promising. But again, we're still not seeing the, and again,
that's very hopeful.
We're talking about what you're seeing on an MRI, which looks great, versus what you're seeing in the office across from you.
Yeah,
and those don't always match up.
Yeah.
For example, sometimes we look at two knees and we see that one knee has horrible arthritis, collapsing of that, and the other one's just mild. And you ask them which one hurts more.
Yeah.
The one without the horrible arthritis.
That can happen.
So these things you see on imaging don't always match up with clinical results.
Yeah, more than just a picture needs to be taken into account.
Yep.
All right, more conventional treatment for the knee. Conventional treatment for knee osteoarthritis includes, number 1, weight loss. Weight loss. We have people who will lose 15 pounds and not need an operation for their pain for their knees.
Yeah, the way that your body mechanics work and just how the pain is transferred to your knees, even that much, losing 10, 15 pounds, can actually make it feel on your knees like more than that weight is coming off of your body, especially when going up.
The mechanics
upstairs.
are weird. I can't say it off the top of my head. Maybe you can, about you take that much weight off the body, but the force on the knees is...
It's more. I don't think it's quite twice as much.
It's a much bigger deal to the knee than it is to the scale. We'll say it that way.
Right.
Conventional treatment includes weight loss, exercise, non-steroidal anti-inflammatory drugs, which are bad on kidneys.
I know. Yeah, you got to consider that.
And intra-articular corticosteroid or hyaluronic acid injections with total knee arthroplasty,
New
for end-stage
knee
knees.
replacement.
But we know that PRP has a role in that and needs to be considered more.
Considered, yeah.
Okay, what do you want to do next? Let's see if our viewers have presented us
What
with
is your joint of choice?
their joint of choice. Oh, Janet has a question. Everybody, Janet has a question. Here's
Interesting.
She says interesting, but her question is, are you both orthopedic surgeons? No, we're not both orthopedic surgeons.
Neither of us are orthopedic surgeons. Even though I'm a tall white guy.
Even though he's tall and works with wood.
Yeah, that's right. It's like the classic.
Tall woodworkers.
If you're a tall, usually a sports guy.
I was going to say.
Tall sports guy. They go into
varsity
orthopedics. Yeah.
Are you sure you're not an orthopedic?
No. Everybody always mistake me for one of them.
Yeah, in residency, they thought that's what you were.
Yep. Yeah.
Knuckles dragging on the ground.
Oh, wow. Now we're going to offend all the orthopedic surgeons out there.
Oh, yeah. All the orthopedic surgeons who
watch our show.
Yeah.
Commenting saying, why are you telling them to do these injections when I can replace their knee?
Taking out their frustrations with a hammer on something.
Wow.
Oh, come on. If there's any orthopedic surgeons
if there's any there, they're going to think that's
They're gonna
hilarious.
laugh. Right.
And then they're going to say, you take care of their kidneys. All right.
That's it. You take care of their kidneys.
I will.
They want our referrals. They'll put up with anything we say. Okay, back to the comments here. Should we move on to
chronic low back? Does it have a place? I have not heard of this.
Well, let's jump into it. For discogenic, so disc pain, stem cell therapy shows promise, but lacks definitive evidence. And so that is why I look askance at having people go out of state for that treatment.
And where are they injecting those stem cells?
I'm guessing it's right into the disc.
Yeah, that's... Injecting anything straight into the disc kind of concerns me anyways, but...
Discitis?
Yeah.
Infection of the disc is bad.
Oh, man.
Bad.
Yeah. You can go south quickly.
Let's read some more for you here. A 2021 systematic review found intradiscal MSC injections are effective for discogenic pain with pooled improvements. Oh, what's that mean when you have to pool the whole group to find that there was improvement? 44.2 points in pain scores and 32.2 points of ODI. I don't know what that is, like activities of daily living type thing.
ODI. Yeah, I don't know that.
Okay. We don't know. 44.2 points in pain
on what
scores?
Scale?
Yeah,
what's your scale there?
Come on, AI.
Help me, open evidence.
Hope you won.
Help me help you.
One 2022 prospective controlled trial, okay, this sounds better, showed that autologous or self-donated bone marrow MSCs injected into multiple spinal structures, disc sets, nerve roots, iliac joints, achieved minimal clinically important difference in ODI in 67% versus 8% of controls.
I gotta look up ODI now.
Achieved minimally clinically important difference in ODI in 67% of patients versus 8. No, that sounds like a big difference to me. Doesn't that sound like a big difference?
The Oswestry Disability Index.
However, this was a single center, non-randomized
0
study.
to 100%.
A 2018 systematic review concluded that while MSCs and PRP came up again, may be effective for discogenic pain, evidence level was 3, 4 on a scale of Roman numerals 1 through 5 due to lack of high quality,
We need more
randomly
studies.
controlled trials.
Need more studies.
So let's talk about it with conventional treatment for chronic low back pain, which includes PT, non-steroidal anti-inflammatory drugs, muscle relaxants, really,
Not if you're over
steroid
65.
injections. Really, should we talk about epidural steroid injections since it came up as conventional treatment?
It is conventional treatment, but when we're talking about evidence,
But
the evidence is probably similar, right?
now you're talking about a study that was published in AFP, right?
Yeah, there was one.
And they found that so many months after,
You were about the same.
about
And
the same as
not-
people who
not a
didn't
huge
get
improvement.
the
Epidural steroid injections, right?
But did they get a sham injection to
Oh
compare
man, I'd
this?
have to review it. You do get a
Or was it
more
compared against
better
conventional?
immediate relief. That's the, I guess the takeaway. So I mean, I still refer for them, and people walk away with improvement.
Dr. Gwain, are we both orthopedic surgeons? We're not both orthopedic surgeons. I just thought that was funny. Okay, let's move on to another part of the body. We haven't
what
had
are we
any
talking about
specific
now?
requests put in. Let's
Where
see.
do I want stem cells injected into me?
We did talk about the knee, right?
Yes,
Yes,
we did the knee.
we did the knee. Oh,
Oh, tennis elbow.
okay. Here we go. Tennis elbow. I'll show you what we're
Let's
looking at.
talk about that.
Evidence for stem cell therapy in lateral epicondylitis is very limited. Should we even talk about it at all? Conventional treatments remain first line, which we talked about before. Physical therapy.
PRP.
Also shockwave therapy. Prolotherapy is listed. And PRP found PRP to be superior to physiotherapy. Oh, I didn't remember that. And shockwave, the ultrasound, at 24 months. So the shockwave, that's actually, my doctor's office does that. Did you know that?
That's right, they do.
But we know, because we looked at the evidence, that a Cochrane study in 2025 found that the PRP is superior to both physical therapy and the shockwave when it comes to tennis elbow.
There you go.
We're gonna have to train in PRP, even if it is a cash only, because some patients will go ahead and pay for it, and they want,
Some will.
and it is.
If there's
Evidence
the
is showing that
evidence,
it's superior.
the evidence backs it up.
I think I'm gonna find a
Class on it.
yeah.
I know how to give injections in that area. Is it just a
because we used to give the steroid injections.
yeah?
Before we found that the evidence was not
That's lacking. Yeah.
okay. And did we do rotator cuff already?
No,
Okay,
that's the last one. I
rotator
think
cuff.
of the things that we've been talking about.
For rotator cuff to
That's
disease,
straight
stem cell
up
therapy,
not recommended.
not currently recommended based on available evidence. All right, let's see what else it says about it. So while small uncontrolled studies of adipose-derived mesenchymal stem cells
Uncontrolled.
showed improvements in pain scores, probably 70 to 90% reduction. What? That's huge. And tendon defect healing on MRI at 1 to 2 years. These were early phase trials without placebo controls. Yeah, but if you're actually seeing
Again, I
guess-
again present
watchful waiting,
what is the clinical relevance of those preclinical things you're
you
saying.
got to compare it, because sometimes you'll be surprised at what you get from watchful waiting, meaning do nothing,
Yep.
and from just time.
Yep.
Things do get better. So
studies are not
you
there.
have to have a control to compare against.
Right.
It's
Yes,
surprising
yes.
sometimes. Okay, let's go back to our wonderful viewers. Oh, okay. So we've got Janet, again, saying, I've had epidural injections in my low back, and then,
I think it's the next line. Rhizotomy.
and a rhizotomy. So rhizotomy, we should tell people what rhizotomy is.
Yes,
Thank you,
that is
Janet.
where you go to a Italian restaurant and order the
Risotto?
Oh no,
That's
no,
a
that's not it.
risotto-otomy. No, it's killing the nerve, right? Probably with either injection
With
of.
rhizotomy, it's specific. Yeah, that one is.
Oh, that's a specific nerve.
No, it was a specific way to kill the nerve.
Or electro. what?
Rhizotomy.
Yeah, electrical
Heat. That's the heat.
Oh,
one.
heat. Okay.
Yeah.
So using heat
Oh wait, that says it could be chemicals or surgical cutting as well, but
surgical cutting.
I guess it's any of those.
So what happens after you cut the sensory nerve that was causing pain? Well, you're probably going to lose more than just pain tracks. You're probably going to lose all sensation in whatever distribution that nerve served.
Yep.
So typically, I think for this, it's going to be like a line going kind of down the buttock and thigh to the knee.
Depending on what level they do it at.
Depending on what level, but that's going to be kind of the classic L. Yep. Oh, is that 3-4 that I'm describing? Mm-hmm. So Janet probably has numbness in a strip on her leg. And most likely it kind of starts in the mid-butt and then goes down, kind of the lateral side there. For where most people would have that done.
Right.
There are other zones, though, that...
Yeah, and it's my understanding that even that is not a permanent solution. Like that is...
Really?
Like the nerves will grow back. It's my understanding that even after 6 months to a year, they sometimes need to repeat that.
So they grow back when it's painful, but they don't when you need them?
Pain returns. Yeah, that's my understanding.
Okay. So you certainly would be interested.
Nerves are pretty amazing at what they do.
Hear how the rhizotomy has done for Janet's pain. Good. Very good. So we have covered in the last 3 weeks prolotherapy, PRP, and stem cell therapy. So keep writing in the comments for suggestions for what questions you want answered on
What's next?
On this
Where
forum.
to go? Where do you want these non-orthopedic surgeons to comment on?
Final recommendation, stem cell therapy for?
Stem cell knees.
And I would say...
And maybe...
My answer would be still in the studies. Don't chase it right now.
Yeah. And again, we're still looking for clinical improvement. So
yeah, I'd probably recommend the PRP over the stem cell therapy.
I think so too. Yeah, based on what we found thus far.
And that's where it shines the most. And then for tennis elbow, do nothing.
Do nothing.
Yeah.
Maybe was it prolotherapy, or it was something that had a little better than.
Okay. So thank you, Dr. Wayne.
Yeah.
Till next time.
Hey, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to stay in good health.